Hey, Dr. Joe here from Atlas Health. Thanks for coming to our part 2 of this series. Why do I have thyroid symptoms even though my lab tests are normal? And for those of you who don't know me, I'm a chiropractic neurologist. I practice in Fairfax at Atlas Health, which is just north of San Francisco. And we are actually just started a YouTube channel. We're going to be doing that here soon. And we'll be sending links to that. And we really like doing these events. Just please share this with people that you know that have some thyroid issues that are unresolved so they can have this information. If you're wanting to get a hold of us here at, you can go to our website at atlas-health.net, or you can go to our client relation manager email, which is contact@atlas-health.net. And that's one of the questions we're getting a lot is do we consult with folks that are not local? And I can say that we can do some consulting with people that aren't local to be a patient. We do exams also in the Bay Area, so it just kind of depends on what level of function you're at. And so today we're going to review a little bit of our part 1, and then we're going to get into part 2. But I want to say that there are so many people that are just depressed and they have constipation, or they're fatigued, and or they have an issue that just isn't resolving, or they've been told they have a thyroid issue and they're taking medication and they maybe aren't feeling as good as they'd like to feel, or they've taken every thyroid supplement and they're just not feeling any better, or they've tried dietary stuff and it just isn't working. And the thyroid is a pretty complex system, and there's a feedback loop with the brain and the gut and these other things that are going on. So I want to say that, first off, I'm a chiropractic neurologist. I'm not a medical doctor, and these videos are not medical. They're not meant to be medical advice, okay? This is just information for you so that you can make an educated decision about what's going on. I'm definitely not an endocrinologist, and we do talk about thyroid medicine as part of understanding the physiology of what's going on here, but I'm not actually making a recommendation that anybody stop taking their medication. And what these classes are about are identifying patterns of thyroid disturbance, but not necessarily getting into treatment specifically for you, okay? And I do not actually treat the thyroid here in my office. Legally, my license does not allow me to treat the thyroid. But on the other side of that, there are a number of people with thyroid symptoms that are not getting better with traditional thyroid treatment. And what they need is a doctor to get in there and figure out what's going on with these thyroid patterns and support the underlying physiological issues, either nutritionally or with body work, et cetera, that address these patterns. And by supporting physiology and doing the right nutrition and the right dietary stuff, that physiology changes and their pattern goes away. So it's not the same thing as treating thyroid disturbance, but what it is it's restoring health, and that's a completely different thing. But I just want to be really clear on that, okay? So last time we talked about 22 patterns of thyroid disturbance, and today was really about going into the 5 big patterns related to the brain function, okay? So if we just review a little bit what we did last time, we know that the thyroid gland, okay, gets its signal from the brain in the form of TSH. Wait, that's pretty good there, I think. TSH, okay, tells the thyroid gland to make T4, okay? And then T4 goes to the liver and gets converted to T3, okay? And then T3 goes to all the cells in the body and tells it to be active. So one of the key symptoms of thyroid disturbance is fatigue. So when fatigue happens, often there's a thyroid component. Now, the deal is with thyroid disturbance, you can have a breakdown in this communication between the brain and the thyroid gland. You can have a breakdown at the level of the thyroid. You can have a breakdown at the level of the conversion, and you can have a breakdown at the level of the thyroid receptor. Okay, so last time was kind of an overview. So we have a breakdown here, a breakdown here, a breakdown here, and a breakdown here. Now, when those things break down, there's actually a way to identify that with labs, with forms, with history, and with exam procedures. We can start to identify where some of this stuff is coming from. Now, there is something called primary hypothyroidism. Primary hypothyroidism is a situation where TSH goes up and T4 is low. Okay, that's called primary hypo. And that is the pattern that most commonly will be tested for in standard medicine, and it will require medication, usually. Okay. But for the people that are taking the medication, and there's a problem here, or there's a problem here, see, this problem is fixed, but there's still an issue here and here, that may not be enough to get them to their goal. That's part of it. Okay, the other thing is that what we're going to cover today are the 5 brain-based patterns. And I love going through these 5 brain-based patterns, because what's essentially going on is the problem is not the thyroid gland, okay? The problem is the brain. And often, if the problem is not the thyroid gland, the person may do thyroid therapies or thyroid interventions because they have all these thyroid symptoms, but it just doesn't work. It's just not happening. So we have to say, well, why is that, okay? And what it is the brain is not telling the thyroid what to do. Okay, so if we take a look at this, like so, there's a low part of the brain called the hypothalamus. That's like the thermostat for a lot of different things, but also for thyroid, okay? And the hypothalamus, this is all part of the brain, the hypothalamus connects to the pituitary gland. And the pituitary gland is what releases TSH, and that's what tells the thyroid to make T4. Okay? Think of the hypothalamus like the thermostat in the room, okay? If the thermostat senses the room is cold, it will click on the furnace. If the thermostat senses the room is warm, it will click off the thermos. The heater, okay, the furnace. So the deal is the hypothalamus is really a big part of this whole feedback loop, okay? Now, remember in primary hypothyroidism, TSH is usually elevated, okay, with low T4. In secondary hypothyroidism, or the brain-based patterns of secondary hypothyroidism, TSH is low or low normal, okay? And then T4 is also low or normal low, okay? So if you're not making TSH and telling the thyroid to make T4, can you see how T4 can be low? So a person may actually need medication for low T4, but it's not because the thyroid wasn't responding to TSH, it's because the brain was never giving the signal. Does that make sense to everybody? So literally the brain is like this. The brain is not sensing there's low thyroid hormone, and so it's not telling the pituitary gland to make TSH and tell the thyroid to go back to work. The thyroid is the factor that makes thyroid hormone. So the hypothalamus can be broken, and it may not respond to therapy, okay? So here's what that looks like. There are 5 things that mess up the hypothalamus in the thyroid parlance, okay? The first thing is something we'll talk about. It's called a prolactinoma, okay? A prolactinoma is a scenario where the person has a pituitary tumor in this gland here, and it's causing them to make high prolactin. Prolactin is the substance that the brain makes to make the breasts make breast milk, okay? And so this can happen in males and females where they suddenly start leaking milk out of their nipples, okay? And the reason they're leaking milk out of the nipples is because they have a pituitary tumor, and not because they're pregnant and or breastfeeding. And so that's a key history. That's a pretty easy history finding, right? So if somebody comes in and they have all the thyroid symptoms and they're told the lab tests are normal, and I'm like, hey, do you ever have anything come out of your nipple, like liquid? And they're like, no. It's probably not going to be prolactinoma. Okay, another issue with pituitary tumor or prolactinomas, they might get a splitting type headache that just won't go away right between their eyes. And if it compresses the nerves that transmit signals from the eyes to the brain so we can see, cross at that area called the optic chiasm, and we can get such a big tumor there that it can compress the optic chiasm, and they can get what's called bitemporal hemianopia, which means they lose their peripheral vision on both sides. So that would be another exam or history finding. So exam finding would be actually testing peripheral vision, and history finding would be, they'd say they're starting to get tunnel vision, okay, and a splitting type headache, and then they also have a little bit of liquid coming out of their nipples. That's probably suggestive of a prolactinoma. That situation, we could also do a blood test and see elevated prolactin, and that requires a referral. And there's some pretty cool like gamma knife surgery that can be done where they don't even puncture or cut through the skull. They use like radiation, a gamma radiation, and they just go right in, they just zap it. Okay, that's one pattern. Okay, the second pattern that I want to talk to you today about is related to elevated cortisol. Okay, cortisol is a hormone that our stress glands produce when we're in fight or flight, when we're pissed off in traffic, when we eat too much sugar and our blood sugar crashes. It's normally elevated in the morning. Some people with PTSD have elevated cortisol all the time, okay? And it can cause weight gain around the middle because it opposes insulin. So folks that are having a little bit of weight gain kind of around the spare tire area, they may have short-term memory loss. So the cool thing about forms and about history is that all the details are there. And so kind of the way that we approach it here at Atlas is we have people do forms, and like on the forms, there's a whole section on low adrenal function, and there's a whole section on high adrenal function, and there's a whole section on blood sugar, and there's a whole section on thyroid. So if we see a person with like all the low thyroid symptoms, but their thyroid levels are pretty normal, but then we look at their TSH and it's kind of low, and we see on the forms that they have some evidence of high cortisol, and we can actually quantify that with like a salivary cortisol test, then we start to go, okay, this person may actually have a pituitary suppression secondary to a cortisol elevation from being stressed out of their mind or from having some sort of issue in their body that they're not aware of that's causing them to have high cortisol. And the number one issue usually being some sort of blood sugar disturbance. And the number two issue being some sort of emotional stress and or PTSD, and the part of the brain that regulates stress just isn't happening, okay? So we're gonna get more specific into the lab test for all the stuff a little bit later on, but that's basically how we identify that, is we do a history, we look at forms, and we might do some labs that look at cortisol, and in the thyroid gland, we might see, or the thyroid labs, we might see a low TSH, which is all of the brain-based patterns, and a low T4, and then the other thing is something called a high reverse T3. So if you've ever done blood testing and you had a high reverse T3, it might be this high cortisol pattern, okay? So like on our brain function assessment form, some questions that might associate with high cortisol would be like lack of short-term memory, okay, or sleep disturbance, okay, inability to get up in the morning, get out of bed, or inability to fall asleep or stay asleep. That might be some cortisol or blood sugar type issues that are affecting the brain. So the person with low thyroid function that has all the thyroid symptoms that isn't responding to what's out there, a doctor that might ask them some questions about their brain related to sleep and related to digestion and acid reflux around meals, related to constipation or diarrhea, around stress, if it gets better or worse with stress, that might be indicating they have the secondary pattern related to high cortisol. Okay, moving on. So far we have a couple of different patterns we've identified. Okay, one's related to a prolactinoma. Two is related to a cortisol problem, which is an adrenal problem, but really isn't an adrenal problem. It's secondary to whatever the lifestyle factors are that are driving adrenals. So the process isn't going to be putting somebody only on an adrenal supplement. The process is going to be understanding why is their cortisol all messed up and then working with that. Okay, that's the Atlas method. Okay, the third thing that I want to talk about is related to dopamine. And it kind of dovetails with the other thing, which is serotonin. Okay, dopamine and serotonin are neurotransmitters that are actually made in the brainstem. So if we look at this graph over here, this right here is kind of like this over here, okay? This right here is the brainstem. This part right here is right behind the eyes, okay? And then the rest of it's a little bit lower, okay? And so the deal is this. This area we make dopamine. This area right here in the middle, we make serotonin. But it projects to the frontal lobes, okay? So that area projects up here to the frontal lobes. We'll call that dopamine. And we'll call this serotonin. So it projects from deep inside the brainstem. And then those projections actually go to the hypothalamus. Boom. Boom. Okay? And so if there's not a dopamine or serotonin projection to the hypothalamus, what happens is the hypothalamus loses its ability to work. So it's kind of like somebody came in and turned off the thermostat in the room. And so now the furnace doesn't kick on or kick off normally, and the room is just like scorching hot, or it's like freezing cold. And in the parlance of thyroid, either you're like super duper tired, or you're gaining weight, or you're like super constipated, and like nothing seems to be working. In this case, you might also be like depressed, right? So there's serotonergic type symptoms, loss of quality of life, not enjoying things that you used to enjoy, overwhelmed with tasks to manage, wake up in the middle of the night, can't get back to sleep, okay? Maybe a little tendency to OCD, okay? And then there's dopaminergic type symptoms like inability to initiate tasks, okay? So like procrastinating, or always needing like chocolate, or person gets pissed off in traffic. Like little things just make them fly off the handle. Like stress, just absolutely, they cannot handle stress at all, okay? That might be a sign of low dopamine. Now, the thing is, there's questionnaires that we can use to identify dopamine issues. There are questionnaires that we can use to identify serotonin issues, but there's also exam findings that we can use to do those things. For example, there's a way to use bedside testing to examine if the mesencephalon or the midbrain is doing what it's supposed to do. There are bedside procedures that we can use to actually examine what's going on with the brainstem to see. Now, some people, they have this. They have normal production of dopamine, and they have normal production of serotonin, but the frontal lobe just isn't responding. Sometimes the frontal lobe isn't responding because of a thyroid issue. So it's like now they get a dopamine and serotonin issue, and they end up with a thyroid issue, and then they got a thyroid issue that causes more of a dopamine and serotonin issue, and then they have this huge vicious cycle that they can't get out of, okay? Now, how do we measure dopamine and serotonin? There are some neurotransmitter tests out there, urinary testing, and just so you know, like this testing, they do these tests on rats, okay? The studies that validate these tests, and rats don't have a blood-brain barrier. So humans do, okay? So if you have a blood-brain barrier and it's intact, what you're peeing out and measuring with neurotransmitter testing is not a reflection at all of what's going on in your brain, okay? There really is no ethical way to go in and measure what's happening in your brain with serotonin and dopamine. We can only use questionnaire, and we can use exam to guide us, okay? But if we find somebody with a secondary brain issue, secondary hypothyroidism due to, for example, we identify their serotonergic circuit, the dorsal raphe magnus nucleus, okay, is producing all these serotonin deficiency symptoms or lack of function, and they have a hypothalamus isn't working, so they have a low TSH, we go in there and we direct therapies to the brain that might increase serotonin firing or circuits to beef up those areas. It's almost like doing bicep curls for that part of the brain. We get these tremendous changes in serotonin, brain function, and TSH can start to go up without any drugs, without any surgery, without any medication, without any dietary change. Okay, and that's the person that goes and exercises and they just feel great. All right, so exercise is a great way to do that. For those of you that are exercising and you feel way better and you're just not exercising enough, or if you think that, for example, you have one of these secondary hypothyroid patterns and you're not exercising, odds of you getting to recovery are very slim unless you start incorporating some sort of healthy fitness, okay? The trick with fitness is this. How do I know what exercise I should do? And then should I go hard, or should I do interval training, or should I go easy and do aerobic training? And if you go to our webpage or our Facebook page, we just posted a video about how to assess aerobic easy training versus anaerobic hard training. So check that out, okay? In regards to dopamine, okay, there's a whole set of examination procedures we can do to evaluate the midbrain. And it might be looking at eye movement. It might be looking at shoulder and hip muscle tone. It might be looking at tension in the limbs. It might be looking at sensitivity to light and sound. People that have sensitivity to light and sound, people that have stiff shoulders and hips, people that have difficulty with motivation, people that fall apart in traffic or have like road rage issues or just rage issues in general may have low dopamine. And people that have low dopamine significantly enough end up with Parkinsonian type symptoms often. Okay, and so what we can do is we can look at the forms, we can look at the exam, we can say this person has low TSH, and then we can intervene very specifically what we're seeing in the brain. And the cool thing is when TSH starts to respond to the activation of the brain, then we know we're on the right track, okay? That's pretty cool. So let's look at the fifth pattern that I want to talk about today, and that's cytokines. Okay, cytokines are messengers that white blood cells use to communicate. Okay, and infectious disease is ubiquitous. It's everywhere. And autoimmunity, if you have, for example, Hashimoto's and you have that type of thyroid autoimmunity, that's a different pattern than what's on the board here, okay? But those cytokines that are attacking your thyroid gland and other tissues could be elevated, suppressing this hypothalamic or breaking the hypothalamus area. So now the pituitary gland becomes suppressed, TSH goes down. Okay, now those cytokines, remember we drew that little picture on the board? Things can go wrong in the brain, things can go wrong in the thyroid, things can go wrong in the liver, and things can go wrong at the receptor. Those darn cytokines, they mess up this loop, okay, here. They mess up the liver loop, conversion, and they mess up the peripheral receptor loop. So when we see infection, that's why some people get so darn tired when they're sick, because their thyroid just doesn't work anymore, okay? When we see chronic autoimmunity, we see fatigue all the time. And why are people so fatigued? Part of the reason is secondary to chronic low thyroid function due to cytokine messing up the brain, the liver, and the receptors as it relates to thyroid function, okay? So let's talk about a little review here about how we can actually do lab tests to kind of identify all these things. A lab test for a prolactinoma would be looking at prolactin levels, okay? A lab test for cortisol, we don't really like blood testing for cortisol here, and the reason is because when you start walking up to somebody with a needle, their cortisol levels are probably going to go up, you know? The second thing is the cortisol elevation or being low is really important, but really what's important is the rhythm. So cortisol should be highest in the morning and lowest at night. And sometimes we see people where it's flipped. We see people that develop autoimmunity and thyroid symptoms right after they switch to a graveyard shift, which completely flips our cortisol and melatonin, and it makes our immune system go crazy. That's a common thing we see in history. But we really like saliva testing for that. And I'm not a big fan of urine testing for cortisol. And the reason is when you do urinary testing for cortisol, you're getting what you're peeing out, but that's like saying, okay, for sure the liver and kidneys are functioning optimally. And a lot of people we see the liver and kidneys are not functioning super hot, or maybe they're bogged down with estrogen dominant stuff, or they're bogged down with endocrine disruptors from plastics in their environment. And so what we're seeing in the urine doesn't necessarily reflect what's going on in the tissue. So we really like salivary testing for cortisol, okay? But that's how you measure cortisol. But one pattern that you might see here related to thyroid, in addition to low TSH, would be elevated reverse T3, okay? Now, for dopamine and serotonin, there's really no good blood test that we can do for that. And there's really no good lab test that I know of that we can do for that. I'm really not a believer in the neurotransmitter testing, particularly for looking at brain function, okay? Now, we're going to talk about neurotransmitters next time as it relates to liver function. And some of those neurotransmitter tests for liver function and the conversion issues we're going to talk about next time actually could be pretty cool, all right? So that might be having use, but just not for these patterns here. Does that make sense to everybody? All right. How do we measure cytokines? There are tests that can be done. They're like cytokine panels you can run through, you know, like LabCorp, but cytokines fluctuate so much. I really like to look at what are called total white blood cell counts with differentials, and that test can be run for like $6 through LabCorp. And you just look at the white blood cell count, and if it's low or chronically low, or if it's elevated, suggesting acute infection, or low, suggesting chronic infection or autoimmunity or some sort of immune reactivity, then that's a big deal, okay? And so we know that that's just going to make the person tired. And it might be a situation where a person could be on the right medication to increase their T4, but because they have elevated cytokines, their hypothalamus still isn't getting the signal. The TSH is low, which, by the way, the TSH does a lot of cool stuff in the body. So we need TSH. And then it also affects the receptors, that story we talked about earlier, and it affects the liver. So you're still getting like 3 different negative impacts on thyroid function. So if you take a thyroid medicine that was prescribed you correctly and you get a little bit better, but then it kind of plateaus, it might be because there's still some cytokine issues. So look at the white blood cell count and see if it's changed. Okay? So to summarize, in a secondary hypothyroid situation, we're going to see a low TSH or a low normal TSH plus a low T4 or a low normal T4 within the functional range, but they're going to have every symptom of thyroid disturbance. And they may have symptoms like brain fog, short-term memory loss. They may have dopaminergic symptoms like inability to get things started, so like procrastination, or like stimulus-bound seeking, like drugs or sex or exercising compulsively, or they might have a serotonin type symptom where they're just a little OCD and they aren't sleeping very well, they're not enjoying life like they used to, they don't enjoy food like they used to, and or they have exam findings that are consistent with dopaminergic or serotonergic issues. Okay, and these brain-based patterns may not actually respond to what's happening at all with thyroid intervention, because you can see that the thyroid is just not getting the signal. If the thyroid doesn't get the signal, how are we supposed to have healthy thyroid function? And so any therapy that neglects to target the brain in that scenario could prove to be inefficient or ineffective completely. So the next time we talk, a week from today, I can't remember if it's at 12:30 or 1 next week, okay, but it's on our event page on Atlas Health. We're going to go over the liver conversion patterns of thyroid disturbance, okay? So that's a situation where the brain patterns may look really good, where the thyroid issue itself might be okay, and T4 is being made, but then T4 is not actually going to the liver and being converted. Liver symptoms of thyroid disturbance are subtly different than brain. Okay, you might not have all the dopamine and serotonin symptoms. You may not have all the elevated cortisol symptoms. You may not have all of the prolactinoma symptoms, which would be like, the breast milk being produced and coming out where it's not supposed to, or the splitting headaches. Okay, in a liver situation related to thyroid conversion, you might have more like sensitivity to chemicals in your environment, or like clay-colored stool. Anyway, we're going to get into that in more detail next time. And the key thing is the right thing at the right time and the right amount, and you get these awesome changes. And so there's just so many people out there that are just suffering with fatigue, mainly fatigue, migraine headaches. They're getting, weight gain, and then they can't lose the weight no matter what they do for diet and exercise. They're struggling in school to learn stuff because their memory sucks so bad. They're having weight gain specifically around the middle. They're having all these digestive issues like constipation and or diarrhea, acid reflux. They may have autoimmunity that's unchecked. They may have so many things that are going on, and doctors are intervening, and they're doing these techniques for acid reflux, so they're doing these techniques for migraines, and none of it's working because they have an underlying thyroid physiology that has gone amiss, and it's not allowing the body the capacity to heal. And the reason that I'm doing these thyroid classes is because people always ask me, why don't doctors know this stuff, or why don't doctors run these tests or figure out it this way? And I would say this, the reason, and we have to give medical doctors a break, okay? Because the reason medical doctors don't look at this is because the paradigm of that model is to say this, there's a symptom, and for that symptom, there's a lab test, and then based on the lab test, there's a drug or surgery that we can do, okay? So if you do a TSH and it's low, what's the drug for that? that's why if they see a low TSH, they often don't do anything. Now, there's one scenario for that that's really important, okay? TSH could be very, very low in Graves' disease. So people that have low TSH, but instead of having low T4, they have really high T4, probably have Graves' disease, and that means they have an antibody to this guy here, or maybe this guy, and that could be a medical emergency, and that's not something we manage here at all, okay? We definitely refer out for that, all right? The other thing that can cause a low TSH would be if you're taking too much thyroid medicine. Too much thyroid medicine and the hypothalamus is working, it might say, hey, look, too much thyroid medicine, let's lower the TSH. Now, the thing is a lot of thyroid medicines are not bioidentical, meaning they're synthetic, like Synthroid or levothyroxine. And synthetic hormones don't show up in the blood. So you could have a normal or even a low T4 on the blood test, but you could have crazy high levels of T4 in your blood because you're taking Synthroid. And your TSH could be low as a result of that. So you have to pay attention to that. One of the hardest jobs that we have here is co-managing meds with the doctors because, getting the TSH dialed in with their medication can be very, 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 very tricky. And some doctors don't see the need for it because they don't look at these other tests because they really don't have a way to intervene for these other things. And some of them want to help out, but they're practicing outside the standard of care when they do that, and they're not comfortable with that. Okay, so let me see if there's any questions here I can go over. Okay, anybody have any questions you'd like to ask me before I call it a day here? Okay, so just a quick summary. There are 22 patterns of thyroid disturbance in the literature. 5 of them are brain-based patterns, meaning there's something going on either with the tumor in the pituitary gland, elevated cortisol, not enough dopamine or serotonin projections, or elevated cytokines that's contributing to a low TSH. Now, TSH, by the way, does something really cool. It doesn't just tell the thyroid to do its thing. TSH has a huge potential to basically dock on all of this tissue here. And what it does is it helps us rest and relax. So people that have low TSH, so say somebody has an elevated TSH and they go on thyroid medicine, okay? And they start to feel better, but they take too much thyroid medicine, what's gonna happen to their TSH? It's gonna go down, okay? When their TSH goes down, the digestive issues like constipation that was getting better on the thyroid medicine may start to come back. And the reason is because they now have low TSH and their brainstem, which is the nerves that come out that control the bowel right here, may not work as well. That's one factor, okay? And then the other factor could be what's called thyroid hormone resistance, which we'll talk about next time when we get into liver and receptor pathologies. Okay. Somebody asked me, do I recommend tapering off thyroid medication or going cold turkey? I love that question. Legally, I cannot comment on medication. I am not a medical doctor. I would lose my license if I recommended somebody change their thyroid medicine without contacting the prescribing physician. So what I recommend is if you have a pattern that suggests elevated thyroid hormone and you're feeling like it's not working for you, find a doctor that understands this physiology and have them work with your prescribing physician to find the right prescription for you and the right dosage. And I spend quite a bit of my time working that out for folks, okay? Because a lot of people I see are on thyroid medicine, and obviously, as a chiropractor or chiropractic neurologist, I don't have that license, okay? But they still need an advocate to help them see that happen. And some doctors are very, very, very open to that, and some of them are not at all. And sometimes we're not able to help people because, unfortunately, their doctor, we're not able to work that out with them. But I can say that for people that are in Northern California and that are near our office, we work with a medical doctor here that's very helpful in that way. And she understands thyroid physiology, and we work really well together. So if people are needing to change their medicine and not getting any help from their existing doctor, and they come visit us here or they're local, we can kind of help facilitate that process if necessary. But again, I'm not licensed to diagnose or treat thyroid disease, but what I am licensed to do is help people understand the underlying physiology, and I certainly can help people address their serotonin issues and their dopamine issues, and I can definitely run labs to identify these patterns, and I can certainly be an advocate for you in that scenario. So that's a great question. What about if you have thyroid cancer and a thyroidectomy, normal thyroid blood testing, taking nitroprusside, but still low thyroid symptoms? Okay, so in that scenario, when you have to take thyroid prescription because you have primary hypothyroidism and your doctor says it's good for you, or you don't have a thyroid gland and it's gone and you're needing prescription, that's where we start looking at some of the patterns we're going to talk about next time. Okay, so we're going to talk about liver conversion patterns, and we're going to talk about thyroid peripheral receptor patterns. And then also, when we start talking about thyroid medication, certain medications have fillers and binders and food colorings and different ingredients to them that might actually be reactive. So next time we're going to get a little bit more into the specifics of the different types of thyroid medications out there so that you can talk to your doctor about what one might be best for you. Okay. Is having low TSH and low reverse T3 the same thing as the T3 you speak of? Well, that would be an incomplete lab test. Low TSH with low reverse T3 might just mean there's not enough T4 to convert to reverse T3. So without knowing more about what's going on with T4 in that scenario, it's hard to answer that question. A person with low TSH and low reverse T3 and low T4 probably has one of these brain-based patterns, yes. Is it common to see a combination of patterns? So that's a great question. And yes, I mean, especially if there's cytokine issue. So I can't tell you how many people that we run labs on and they have low normal white blood cell count and they're fatigued. And what they have is they have undiagnosed inflammation in their body from cytokine elevation, from the immune system freaking out on something, either an infection or their own body. There's some really cool testing out there we can do to look at what the cytokines are targeting. Okay, we can do lab testing for antibodies through a lab called Cyrex, which is great. We can do infectious disease testing through numerous different labs, and we can identify where that's coming from. But people that have cytokine patterns tend to have hypothalamus issues. Yeah, that's the cytokines. That's the white blood cell communication thing we talked about. They tend to have liver conversion issues, which we talked about at the start of this video, and they also tend to have peripheral receptor site issues. People that have cytokine elevation really tend to plateau on their thyroid medicine, or they're just told their lab tests are normal and, their lab tests are normal, but they're having low thyroid function because they have like 5 or 6 thyroid patterns going at one time. Absolutely. And that's where we just got to walk through each one of those factors. We need to come up with a strategy for each one, and then we just kind of take each one off the board as we support the underlying physiology. So we're not treating thyroid condition in that scenario. Just want to reiterate that. What we're doing is we're supporting the underlying physiology so that that thyroid physiology can improve and they're no longer expressing those symptoms. It's a lot of verbiage, but it's very significant that we are clear on that. Okay. So that's all the questions. Thank you so much for your time today. I'll look forward to seeing you next week. And I believe that information is the key to the recovery for a lot of people, and then application of that information. So thank you for your time, and please share this with people that you feel like really could benefit from this information. We'll see you next time.